So I'm just going to move on to the third case. This is a gentleman this time who was diagnosed with diabetes at the age of 27. This was picked up when he presented to his GP with thrush. So he was noted to have glycosuria. He had a fasting plasma glucose, which was 7.3, and he also had a oral glucose tolerance test, which is at its baseline was 9.6, rising to 11.3 at 2 hours. So what kind of diabetes do you think this gentleman has? And I wondered whether there was anyone that felt brave enough to tell me what kind of things might push you towards one thing or another. I guess we all know that he's going to have HNF1A MODY eventually, but what might you think? What might make you think that he hasn't got? What might make you think that he's got that now? Well, one of the things that we've already talked about is it would obviously be worth asking about family history in this case. So he hasn't got any family history. Asking about other symptoms, so in terms of the first case, whether he's got any symptoms of hypoglycemia, that he was otherwise completely well. Has he got features that would fit with young onset type 2 diabetes? So he's not overweight, he hasn't got any features of insulin resistance, so no acanthosis, not hypertensive and not dyslipidemic. And we also did pancreatic beta cell antibodies to look for an autoimmune basis to this gentleman's diabetes, and both GAD and islet cell antibodies were negative. So there's no feeling that this is type 1 diabetes, and so the working diagnosis of this was this young onset atypical type 2 diabetes. And so he was started on a low dose of glibenclamide, 2.5 milligrams daily. And he maintained good glycemic control with that, so with an HbA1c that was typically under 7%. But he did note that he had quite marked hyperglycemia whenever he tried to increase his glibenclamide doses further. And because he complained about that, his GP switched him to metformin, and it was noted that his HbA1c deteriorated quite markedly to 8.2% after a relatively short period of time. And again, that stimulated a referral up to the hospital. And because of the complaints about hyperglycemia on a sulfonylurea, despite the fact that he had no family history of diabetes, it was considered that he might have an HNF1A mutation. And again, this was confirmed, and a genetic test confirmed HNF1A MODY. So looking again at what the implications for this gentleman are, so this family tree again, he doesn't have any relatives that are older than him that's got diabetes, but he has got 2 children, which at that time it's a 3-year-old daughter and a 1-year-old son. So thinking about what you tell him in terms of having a genetic diagnosis, he's got a 50% chance of having passed on this HNF1A mutation to each of his children. Now that's a difficult thing to say to someone, and something that patients often ask is whether their children can have a genetic test in order to confirm this one way or another. Now, in general, we recommend that predictive genetic testing shouldn't be recommended to people who are too young to be able to make that decision for themselves. And so obviously at that sort of age, you can't make any kind of informed consent about what the implications of a positive or negative test involve. The sort of more practical advice that we offer to these patients is that they should screen for early onset diabetes. So HNF1 alpha doesn't typically present with diabetes before the age of 10, so it's probably not a concern for these children immediately, but you could consider using something like urine glucose to look for glycosuria in these patients going forward. That's obviously a non-invasive test that might help us pick out these patients at an early stage if they do have the mutation. So I think the lessons from this case are that in someone who you're struggling to make the diagnosis about whether they have type 1 or type 2, it might be that they don't have either, and that one of the more rarer types of diabetes, such as MODY, should be considered in these patients. And just to reiterate that, looking on the left-hand side of this box, so in those who've got a clinical label of type 2 diabetes, The features in this case that were slightly unusual was that he presented at a relatively young age of onset, so under the age of 30, didn't have any features of insulin resistance, and he had marked sulfonylurea sensitivity. He didn't have a strong family history, which, as we've discussed earlier, is one of the features that you see and has traditionally been part of the MODY diagnosis, but he still was someone who obviously has a de novo mutation, and so not having a family history should not be a reason not to offer these patients genetic testing. So just to summarise what I hope I've emphasised over the last 3 cases is that a molecular diagnosis of HNF1 alpha MODY has implications both for the individual patients and particularly in HNF1 alpha MODY, the pharmacogenetic effect. So these patients are exquisitely sensitive to sulfonylureas, and really this should be offered as the first-line therapy for these patients, which is important difference from both type 1 and type 2 diabetes. And there are obviously important implications for family members. And I would urge you to consider HNF1 alpha MODY in those who've got atypical features of their applied diagnostic label of diabetes. Thanks for listening.
Thank you very much. And the cases are open for discussion. So.
Thanks a lot for those very useful cases. A few comments and observations. The last case, quite unusual OGTT, very high fasting glucose level and very low increment. How would you explain it?
Yeah, no, I agree. So it wasn't a typical one. His previous fasting glucose was much more typical of HNF1 alpha, so more like 7. I think we discussed this before, and I wonder whether actually there was something that went wrong in that oral glucose tolerance test, and whether the fasting is just a spurious result, because the increment in that case was actually about 3 millimoles, which is, again, as we discussed earlier, not typical of HNF1 alpha MODY.
Okay. And some comments concerning case number 1. Actually, I think that you pointed out to the problem that is very much underappreciated. What I mean is that in general, in monogenic diabetes, not only in MODY, when you switch from insulin to oral hypoglycemic agents, meaning especially sulfonylurea, you see a substantial drop in body weight. And this is one of several benefits that those patients experience. The same is happening, for example, with PNDM. We also see a substantial drop in body weight. I think this should be reminded from time to time. Thanks a lot for doing that. The other comment, observation, you treated this case with gliclazide in traditional form. Probably in this country, we would use gliclazide with modified release. Well, it's highly, the marketing around this form is quite intensive, and the fact is that the majority of gliclazide is used in this form. And however, I'm wondering whether you see, for example, a tendency to hypoglycemia while using the traditional form in the morning, and a tendency to hyperglycemia in the evening, or the profile is just flat.
I haven't noticed particularly hyperglycemia in the patients that respond to low-dose gliclazide, but you're right, we do notice some hypoglycemia, and it tends to be patients saying that in mid-morning to before lunchtime. Saying that, I guess our concern with using a slow-release gliclazide form would be that if a patient was hypoglycemic on a dose, then that's obviously going to have a long half-life in terms of having that effect, whereas at least with the gliclazide usual, it's going to have been worked out of the system, so that you have got the option of titrating down or up as necessary.
Okay. Well, almost all the patients with HNF1 alpha MODY that we provide the medical care are on modified release gliclazide. The dose of 1 tablet is quite small, so if you start from that, there should not be a problem. And one more, not very probably medical comment, but you showed this letter from this patient, and I think it is very typical. Those patients are not very plural, but the intensity of the personal relationships is sometimes so strong that you will remember them for the rest of your life, and they will remember you for the rest of your life. Okay?
Yeah.
Thank you very much.
Thank you. Any other comments, questions, remarks? So I have one short question. Did you look at your patients' lipid profiles, and did you compare carriers versus non-carriers in your families?
So these were all clinical cases, so not particularly in these cases. It has been something that people have looked at previously in terms of lipid profile and HNF1A MODY, and I think we've discussed it at previous C3 meetings about particularly having an HDL that might be higher in HNF1 patients and whether that offers a protective cardiovascular benefit going forward. But we didn't look at it in these particular cases.
I just wanted to mention one more thing that Guy touched on, a patient who had sulfonylurea stopped because of hypoglycemia, and we've seen this on a number of occasions, and the thing is just to go lower, not to stop it. Sometimes people just can't tolerate it, but the general physicians tend to just stop it and change the metformin, so just go low.
Okay, thank you very much.
Thank you.
I think we can move to another cases.